d'avoir avec nous comme orateur professeur Leila Abid, que tout le monde connaît. Elle n'a pas besoin d'être introduite. Je ne sais pas pourquoi je parle en français d'ailleurs. Tout à coup, so it's okay. I apologize. I switched to French, automatically. I think that must be the genes working. But anyway, I just would like to welcome all of you to this Sanofi Symposium. And it's my pleasure to have with us as a speaker, Professor Leila Abid. She does not need any introduction. She's the immediate past president of the Tunisian Society of Cardiology and Cardiovascular Surgery. Leila is very dynamic cardiologist before even becoming an eminent president of the society. And it's a pleasure to have her. I would like also to welcome Dr. Qais Batikh. He's the co-director of Pafcic. And I would like, of course, to thank Sanofi for their continuing support over the years. Sanofi have never missed one single year without participation in Pafcic, whether it is organized in Tunisia or anywhere else across the African continent. So, Leila, the floor is yours. I think you're going to be talking to us on the role of Clopidogrel in 2020. Leila, welcome.
Thank you, Professor Gamra. First of all, I'd like to thank all the steering committee for the invitation, and particularly Professor Gamra and Dr. Batikh for their kind invitation. I'm very, very pleased, very delighted to share with you this session, and congratulations for this great, wonderful virtual meeting. I'd like also to thank Sanofi for the invitation and for the choice of the subject, which is very interesting, the role of Clopidogrel in 2020. The Clopidogrel is a mainstay treatment of atherothrombosis, and as you know that atherothrombosis is the common underlying process for numerous progressive manifestations of cardiovascular disease, including coronary artery disease, cerebral vascular disease, and peripheral artery disease. In the large rich registry of patients with documenting atherosclerosis, 44% of patients with coronary artery disease were found to have polyvascular disease, and 8% were recorded as having prior commitment cerebrovascular disease. And the triad of coronary artery disease, cerebrovascular disease, and peripheral arterial disease was present, as you see, in 1.6% of patients. And as you know that the PDY12 inhibitors, of which Clopidogrel was the first, play an integral role in antiplatelet therapy and therefore in the treatment and secondary prevention of cardiovascular disease. And the aim of this presentation is to discuss the available evidence concerning antiplatelet therapy in patients with cardiovascular coronary vascular disease, and with a focus on the role of Clopidogrel. Although never more potent, P2Y12 prasugrel ticagrelor show a greater reduction in ischemic risk compared with Clopidogrel in randomized trials in patients with acute coronary syndrome. There are often these new antiplatelets are often associated with an increased risk of bleeding. So the question is the exact role of Clopidogrel and the newer P2Y12 inhibitors in different clinical settings. And the other question, what is the role of Clopidogrel? The game, is it over for Clopidogrel? Must it be buried? We'll try to answer this question all over this presentation. And you know that Clopidogrel is a second generation of antiplatelet, and the prasugrel and ticagrelor are third generation inhibitor, P2Y12 inhibitors, that were developed to address the slow onset and heterogeneity platelet inhibitory properties of Clopidogrel. And if we look to the recommendation, the choice of antithrombotic treatment depends on the balance between ischemic risk and bleeding risk, and depends on many other criteria and parameters such as patient characteristic, clinical presentation, comorbidities, co-medication, and procedural aspects. So what's the choice of the new antiplatelet therapy according to the clinical presentation in acute coronary syndrome, in after myocardial infarction, and in coronary chronic syndrome? So if we look to guidelines, and especially European Society of Cardiology guidelines update on dual antiplatelet therapy, particularly in acute coronary syndrome, we find that ticagrelor and prasugrel are the main state treatment in acute coronary syndrome with the loading dose. And we find clopidogrel in the second steps. That means the clopidogrel is indicated in acute coronary syndrome patient who cannot receive ticagrelor or prasugrel. And if we look to the new guidelines of non-stent segment elevation acute coronary syndrome published recently in 2020, and especially the patients who underwent a percutaneous coronary intervention, we find the same thing, that a P2Y12 receptor inhibitor is recommended in addition to aspirin and maintained over 12 months. And options are prasugrel. In the first step, we find prasugrel, we find ticagrelor, and clopidogrel is indicated only when prasugrel or ticagrelor are not available. And the new in these guidelines is the fact that prasugrel should be considered in preference to ticagrelor for NSTE acute coronary syndrome patients who proceed to PCI. And this new recommendation is related to the results of the new clinical trial ISAR-REACT, which compared ticagrelor versus prasugrel in patients with acute coronary syndrome undergoing coronary angiography. And the results of this study were in favor of prasugrel in patients with acute coronary syndrome. So what are the results of the clinical evidence? That means the randomized clinical trials. In fact, the guidelines are based on these clinical trials. We begin with the CURE trial. CURE trial, it's a large study, included 12,000 patients with acute coronary syndrome. And the aim of this study was to show the benefit of clopidogrel versus placebo in the reduction of primary outcomes. What is a composite primary outcomes, including death from cardiovascular causes, non-fatal myocardial infarction or stroke during the 12 months. And the result of this study was in favor of clopidogrel, which offers a highly significant risk reduction, 20% relative risk in patients with acute coronary syndrome in the early and long-term period. And if we look to the subgroup of CURE PCI group studies, patients with acute coronary syndrome who underwent a PCI, the results were in favor of clopidogrel, and that explained and showed the role, the place of ticagrelor in prasugrel in the guidelines and recommendation. And there is many studies, many randomized clinical trials that shows the greater reduction in recurrent ischemic events with this novel agent compared to clopidogrel. Studies Plato with ticagrelor, Triton-Timi 38 with prasugrel. However, the new P2Y12 were associated with an increased risk of non-fatal bleeding complication as well as non-bleeding adverse effects. So if we look to the Plato study, which compared ticagrelor versus clopidogrel in acute coronary syndrome, the role of this study was to evaluate the safety and efficacy of treatment with ticagrelor compared with clopidogrel among patients with acute coronary syndrome, with or without ST segment elevation. And the primary endpoint was a composite response composed of cardiovascular death, myocardial infarction, and stroke. And as I said, ticagrelor significantly reduced the composite endpoint by 12 months compared to clopidogrel without increasing major bleeding and fatal bleeding with a significantly way. And but if we look to the Triton study, Pafcic versus Clopidogrel for PCI patients in acute coronary syndrome, the results of the study were in favor of Pafcic, but we have, on the other hand, an increase of major bleeding and life-threatening bleeding in the group of patients taking Pafcic. But if we look to this recent study, it's a randomized study comparing clopidogrel versus ticagrelor or Pafcic in patients aged 70 years or older with non-ST elevating coronary syndrome. It was a randomized study including 1,000 patients, and the results of this study was in favor of clopidogrel. The result, clopidogrel is a favorable alternative to ticagrelor because it leads to fewer bleeding events without an increase the combined endpoints of all-cause death, myocardial infarction, stroke, and bleeding in this especially population, that means elderly patients who are aged more than 70 years. If we look to this study, the treatment adherence was in clopidogrel 51% versus 30% in group ticagrelor or Pafcic. And the most common reason for non-adherence to treatment was bleeding and dyspnea, which was a side effect of ticagrelor. So, what is the role of the newer P2Y12 inhibitors in acute coronary syndrome? Acute coronary syndrome, there are the mainstay treatments, but especially non-STMI, acute coronary syndrome with persistent ST elevation is the mainstay indication for this new antiplatelet therapy. And the majority of studies encourage the fact of giving these new treatments earlier in STMI. And you look to this meta-analysis that show the majority of the studies are in favor of early administration of the new antiplatelets in STMI. What about what is the place of this antiplatelet in case of fibrinolysis? Recommendations are here. In case of fibrinolytic therapy, clopidogrel is indicated in addition to aspirin. There is no place to the newer antiplatelet therapy. And I'd like to show you this study trial comparing the ticagrelor versus clopidogrel in patients underwent thrombolysis, and the patients were randomized with a median of 11 hours after fibrinolysis, wasn't immediately after fibrinolysis, and 90% of patients were treated with clopidogrel. It was a safety study. So in this study, ticagrelor didn't increase the incidence of primary outcomes, which include major bleeding. And if we look to the other criteria, death from vascular diseases, myocardial infarction, or stroke, there isn't also an inferiority of ticagrelor versus clopidogrel. The trial studied these effects during 1 month. But if we look to the subgroup of the study, which followed up the patient during 1 year, we find also that ticagrelol doesn't decrease the ischemic events in patients who benefited from ticagrelol after fibrinolysis. So it's clear that we should give this treatment early in STMI, but in case of non-STMI, we should give this antiplatelet later. And if we look to the new guidelines, it isn't recommended to administer routine pretreatment with a P2Y12 receptor inhibitor in patients in whom coronary anatomy is not known, and an early invasive management is planned. And there are many treatments dealing with the necessity of pretreatment in acute coronary syndrome without ST elevation, and the majority of these studies were negative. They don't encourage pretreatment in case of acute coronary syndrome, except of the studies comparing clopidogrel with the others in acute coronary syndrome, such as CREDO, PCI, CREDO. So the second question is about the DAPT prolongation to improve post-acute coronary syndrome prevention. The recommendations are clear. We recommend 12 months DAPT, but you know, and as show these registries and the epidemiological data, that for patients who had a history of myocardial infarction, at 3 years, they are at risk to develop death or myocardial infarction or stroke. And this risk was estimated about 20%. So we need sometimes, in some patients who are at high risk, ischemic high risk, we should look to the prolongation of DAPT. And if we look here to the recommendation, DAPT in the form of aspirin plus ticagrelol or prasugrel, or clopidogrel, if ticagrelol or prasugrel is not available or is contraindicated, is recommended for 12 months after PCI. This is the case of patient after ST elevation myocardial infarction. But if we look to the new guidelines of non-ST acute coronary syndrome, the same thing for the patient who are at low risk, at low bleeding risk. They need 12 months treatment duration, but sometimes, and you see here in case 2A or 2B, we need to prolong the duration of antiplatelet therapy, and it depends on the ischemic risk of the patients. There are many options for extend the dual antithrombotic antiplatelet therapy. It could be clopidogrel, it could be prasugrel or ticagrelol, even rivaroxaban in some patients. And if we look to the recommendation in class 2A, indication of DAPT more than 12 months in patients at high risk for ischemic events and without increased risk of major bleeding. And it is a class 2B indication for DAPT more than 12 months in patients with moderately increased risk of ischemic events. And in the guidelines, they specify the risk criteria for extended treatment with the second antithrombotic agents. They based on there is a risk enhancer, a cardiovascular risk such as diabetes, such as multivascular coronary artery disease. There is also other risk enhancers such as concomitant systemic inflammatory disease, chronic kidney disease, technical aspects, at least 3 stents implanted. There is also another technical aspect such as the length of the stent, total stent length more than 60 millimeters. So we should evaluate the ischemic risk of our patient to decide about the duration of the DAPT. And if we look here to the guidelines, adding a second antithrombotic agent to aspirin for extending long-term secondary prevention should be considered in patients with a high risk of ischemic events and without increasing risk of major or life-threatening bleeding. So this is a summary of the guidelines, but what about the randomized clinical trials? Are they in favor of extending the DAPT more than 12 months? The majority of the study, Charisma, Pegasus, are in favor of extending DAPT more than 1 year after myocardial infarction. For example, if we look to Pegasus study, which included stable patients with history of myocardial infarction, 3 years prior, and they have also another additional atherothrombosis risk factor, such as diabetes, multitruncular disease, chronic kidney disease, and patients were to aspirin, and they will be randomized in 3 groups, the different doses of ticagrelor or placebo, and they were followed up until 1 year. And as you say here, there is a difference between the group which take ticagrelor versus placebo. There is a significant reduction of the primary criteria, including cardiovascular death, myocardial infarction, or stroke. But on the other hand, we have a bit increase of bleeding, especially major bleeding. The same thing, the results of DAPT, tenofovir prolongation beyond 1 year after stenting. The results was encouraging to extend the DAPT more than 1 year. And as you see here, this meta-analysis summarize the majority of studies dealing with the importance of prolongation of DAPT after stenting in myocardial infarction. So, in case of patients who are in high risk, ischemic risk, and low bleeding risk, it's recommended to extend the DAPT more than 1 year, but sometimes we should individualize the duration of antiplatelet therapy, the DAPT, because of, especially in patients who are at high risk bleeding, we should evaluate the risk bleeding in each case, and we should look especially to the renal function, the age, and if the patient had prior major bleeding or prior hemorrhagic stroke. There are the main parameter in which we should look to evaluate the bleeding risk of the patients. The guidelines propose us the score, a precise DAPT score also. It's a validated score to evaluate the bleeding risk of the patient, but we also, as I said, we should evaluate the ischemic risk of the patients, taking off the cardiovascular risk of the patient, but also the anatomic characteristics of the lesions, the technical characteristics, the length of the stent, and the question is how should we shorten the duration of DAPT? And there is also a new concept, the concept of desescalation. Effectively, in the last few years, thrombotic complications have decreased with the use of the latest generation of drug-eluting stents. And while awareness of the impact of bleeding complications for adverse outcomes, including mortality, has increased. And the need for an optimal balance between ischemic benefit and bleeding risk, as well as reducing the risk of non-bleeding adverse effects as ticagrelor-related dyspnea, has led to the development of DAPT desescalation. That means the switching from a more potent to a less potent P2Y12 inhibitor usually Clopidogrel. And the escalation has emerged as a medium to long-term bleeding reduction strategy in patients after PCI when thrombotic risk decreases, but the bleeding risks presents, and in patients who are unsuitable for long-term potent and more expensive anticoagulant agents. So we should take we should focus on this balance between the risk of thrombosis and the risk of bleedings. And clinical trials have assessed the benefits of that desescalation in patients with acute coronary syndrome, such as a topic trial. It was dealing with acute coronary syndrome patients undergoing PCI. And after 1 month, the patients were randomized and changed that. That means aspirin with a newer P2Y12 blockers, or to another DAPT, that means aspirin with Clopidogrel, and the follow-up was 1 year, and composite primary endpoints was death, stroke, back bleeding more than 2. And the results of this study were in favor of switch DAPT, that means the association between aspirin and Clopidogrel in reducing the primary criteria, including death, stroke, and back bleeding more than 2. But there isn't significant effect on ischemic events. Unfortunately, there was an increasing of bleeding in the group of patients who were under aspirin and the newer antiplatelet. So the study topic trial was in favor of the association aspirin Clopidogrel switching the new antiplatelet by Clopidogrel. This study was criticized because it was a monocenter study, and the sample was about 500 patients. It isn't a large study. And if we look to the recommendation, the new recommendation, the de-escalation of P2Y12 receptor inhibitor treatment, that means a switch from prasugrel or ticagrelor to Clopidogrel, may be considered as an alternative DAPT strategy, especially for acute coronary syndrome patients deemed unsuitable for potent platelet inhibition. And this escalation may be done and guided based on clinical judgment or guided by platelet function testing or by genotyping, depending on patient risk profile and availability of respective assay. This is about the escalation which we needed in some cases in our real life practice. So how we should we do this switch between the antiplatelets? For example, if we will switch ticagrelor to Clopidogrel, we need to give the patient loading dose of Clopidogrel 24 hours after ticagrelor. And if we switch ticagrelor for prasugrel, it's the same thing. We should give a loading dose, but if from Clopidogrel to ticagrelor or prasugrel to ticagrelor, we don't need a loading dose. Now I will talk about another situation when we need triple antithrombotic therapy, that means anti-DAPT, but with oral anticoagulant in case of atrial fibrillation. And you know that the majority of study, and especially our Tunisian registry Nature AF, 30% of coronary artery disease patients have atrial fibrillation. So it isn't a rarely situation. And if we look to the recommendation about the combining antiplatelet agents and anticoagulants in non-ST segment elevation acute coronary syndrome patients requiring chronic oral anticoagulation, you find that in patients with atrial fibrillation who need anticoagulation, after a short period of triple anticoagulant treatment up to 1 week from the acute events. That is recommended as a default strategy using AOD as the recommended dose for stroke prevention and a single oral antiplatelet agent. And in this case, it's preferably to use Clopidogrel. And the discontinuation of antiplatelet treatment in patients treated with no AC is recommended after 12 months. In case of the patient treated with VKA, case of mechanical prothesis valve, Clopidogrel alone should be considered in selected patients, especially patients who are at high risk bleeding and low risk of stent thrombosis for up to 12 months, and it's a recommendation class 2E. What is about the use of ticagrelor or prasugrel in case of needing anticoagulation, atrial fibrillation? The use of ticagrelor or prasugrel as part of triple anticoagulant treatment is not recommended. So in this case, we can use only Clopidogrel. And this is the algorithm of the antithrombotic therapy in non-stage segment elevation acute coronary syndrome, patient with atrial fibrillation. Donc 1 week triple therapy. After that, we have 12 months of double therapy, single antiplatelet therapy, Clopidogrel with oral anticoagulant. And this is the case of patients who aren't in high risk bleeding. And here, the dose, for example, for rivaroxaban, if we will associate it with Clopidogrel, it can be 50 milligram per day or 20 milligram per day. It depends on the bleeding risk of the patient. So I think that the key message is that triple antithrombotic therapy should be as short as possible in this situation. So I summarize the place of Clopidogrel based on the guidelines, based on the clinical trials, but what is the results of the real life world studies? And there were many registries, European registries, American registries, who focused on Clopidogrel in acute coronary syndrome, but in our real life. The common results of this registry that Clopidogrel was administered especially in older and sicker patients, that a large number of patients continue to take Clopidogrel, and there were more bleeding complications with the newer antiplatelet therapy. The third indication for antiplatelet therapy, the chronic coronary syndrome. Do the newer antiplatelet therapy have a role in a chronic coronary syndrome? If we look to the guidelines recommendation of chronic coronary syndrome published in 2019, you look here, Clopidogrel daily following appropriate loading dose is recommended in addition to aspirin for 6 months following coronary stenting, irrespective of stent type. So in chronic coronary syndrome, the treatment of choice is the Clopidogrel. And if you look to the new trial presented in November in American Heart Association meeting, and it was recently published in the Lancet, the ALPHEUS study, and this study compared the role of ticagrelor versus Clopidogrel in reducing severe complications after elective PCI, and the results of the study that higher level of platelet inhibition obtained by ticagrelor doesn't translate into a reduction of peri-procedural myocardial infarction or myocardial injury within 48 hours of high-risk PCI performed in stable coronary patients. And ticagrelor use for 30 days didn't translate in increased major bleeding rate, but there was an excess of minor bleedings and dyspnea. So these results support the Clopidogrel as the standard of care in chronic coronary syndrome. So the role of Clopidogrel and the other antiplatelet therapy is very, very important in acute coronary syndrome, in chronic coronary syndrome, in myocardial infarction. But what about cerebrovascular disease, vascular stroke? And to ask this question, I will talk about a Capri study, which included patients who had myocardial infarction, stroke, peripheral artery disease, and there was two groups of patients, the patient under Clopidogrel versus aspirin, and these patients were followed up during 5 years. And the primary criteria was the incidence of first occurrence of ischemic stroke, myocardial infarction, or vascular death. And the results of Capri study showed the benefit of Clopidogrel versus aspirin in reduction of the primary criteria. So if we look to the guidelines, the American Heart Association, American Stroke Association, they recommend the use of DAPT, aspirin and Clopidogrel, 21 days in patients with minor stroke. And it's the same thing of the Canadian stroke guidelines, who suggest the association of Clopidogrel, aspirin, in case of transit ischemia accident. And for the peripheral artery disease, it's another indication for antiplatelet therapy. If we look at, based on the study, and if we look to the guidelines of the European Society of Cardiology and the European Society of Vascular Surgery, the long-term single antiplatelet therapy is recommended in symptomatic peripheral artery disease patients, in all patients who had undergone revascularization, and in both cases, Clopidogrel may be preferred over aspirin. So my key message, if we try to summarize the indication of this antiplatelet therapy, in case of STMI, the new P2Y12 is the mainstay treatment of STMI. In case of fibrinolysis, the treatment of choice is Clopidogrel. In case of after myocardial infarction, in the case of patients who are at high ischemic risk and low bleeding risk, we need to extend the DAPT more than 12 months. And DAPT is compound of aspirin and Clopidogrel. In case of NSTMI, it's inhibitor of P2Y12 inhibitors are the treatment of choice. In chronic coronary syndrome, Clopidogrel, and we need sometimes to switch new antiplatelet therapy for Clopidogrel, especially in patients who are at high risk bleeding, and we now discuss about individualizing the treatment of patients who have coronary artery disease. So we have the strong evidence supporting the efficacy, safety, and cost-effectiveness of Clopidogrel for antiplatelet therapy in several different clinical settings. We are familiar as a medical committee to use Clopidogrel. He is available with a low cost compared with the new antiplatelet therapy, and it remains an important medication in clinical practice and the mainstay of antiplatelet therapy. And thank you for your attention.
Thank you very much, Leila, for this brilliant presentation where you have gone over were giving us an overview on the antiplatelet effect of clopidogrel over the years, and you have shown us very clearly that this drug is far away from being forgotten, and it is clearly here to stay. And by the way, and everybody knows, although recommendations now, they general guidelines, they recommend the new antiplatelet therapy unless clopidogrel is not available, but that's for the common patients, for the majority or the common patients. But as you have shown us, there are subset of patients where actually you just have clopidogrel and it's only drug to be given, such as high bleeding risk patients, and you have shown in the guidelines, and this is one of my question, by the way, to you. In very high bleeding risk, the only option is to have aspirin and clopidogrel for 1 month, and then keep going with clopidogrel only as a single antiplatelet therapy. Now, for patients with a high bleeding risk, not very high bleeding risk, a little bit, lower degree of risk, then it's the same aspirin plus clopidogrel for 3 months now, and then one single antiplatelet therapy with aspirin, not clopidogrel. And this is quite strange in the guidelines. So someone might ask why it's not clopidogrel. You see what I mean? So, and I think that this is an option. I mean, and many of the clinicians, they just keep one of them. It depends on the economic resources of the patient, whether the patient is able to use aspirin, to buy aspirin, or to have clopidogrel.
Thank you, Dr. Gamra, for this comment. Effectively, in our practice, we should evaluate our patient before prescribing antiplatelet therapy. And as you said, for the patients who are at high risk bleeding, not very high risk bleeding, we find that after 3 months, we have aspirin and not clopidogrel. I don't have explanation, but probably because with aspirin, we have less bleeding complication. I think I have this explanation. I don't know if you have another explanation of that.
No, I don't. That was my question. So I would like to welcome Professor Habib Bousadi and Professor Fahmi Ramedi, who have joined us for this symposium. Any question? Si Fahmi, si Habib, Qais?
Thank you, Leila, for this good exposition of the remaining place of clopidogrel, but we know that this is the most prescribed now in Tunisia. We know that there is the most potent antiplatelet therapy now is coming for acute coronary syndrome, especially, and we are also this new treatment will give us a better improvement of patient at high risk of thrombotic risk. But we have other patients that they are at high risk of bleeding. And this is a problem with dilemma with giving potent treatment for both of these patients. So we know that the problem is that the patients who are at high risk bleeding are also at high risk of thrombotic events. So how to choose the right patient for the right treatment?
I think I agree with you, but I think that it depends on the clinical presentation. That means I think that if I have a patient with STMI, I prescribe a potent antiplatelet, the new antiplatelet, only for 1 month because I need the antiplatelet effect of this antiplatelet. But after that, I should switch to clopidogrel because we will have less bleeding complication.
So, Leila, you're recommending and adopting the topic trial regimen. But I think personally, it was a great idea that trial that was performed by Thomas Cuisse in 2017 and published. by the way, at that date. I think it's quite interesting. Now, you have shown us in the guidelines that strategy was given only 2B recommendation. And in my view, it was given only 2B because there is only one single trial, and it's not a very large one. So it's only 650 patients, something like that. But it is very elegant trial. I mean, it has shown that actually, if you keep ticagrelor and prasugrel, I think 50 and 50, I think, if you keep ticagrelor or prasugrel for 1 month, and then you switch to clopidogrel, you will cut by half. You will cut by half the risk of death, bleeding, and I think hospitalization, but you will keep the same risk of ischemic event, which is quite interesting. So this is something that might be an answer to Qais' question, by the way. So you might protect your patients, particularly after acute kidney syndrome, by a higher, more potent antiplatelet agents such as ticagrelor, for example. And after that, you switch to clopidogrel, where actually you will have a quite good coverage from the ischemic event, but without an exceeding risk of bleeding.
Yeah, surely. I agree with you, Dr. Gamra. It's a very interesting study. It was criticized because it wasn't enough large, and it was a monocentric study. There was only one center conducting the study. But I think that if we will conduct a larger study, it will help us in our practice, and the strongness of this recommendation will change from 2A to 1 class 1. And I think even in our practice, in daily practice, we are giving the potent antiplatelet ticagrelor because it is available in Tunisia for 1 month, at least 3 months. And after that, we switch to clopidogrel because there is the problem of costliness. The patient can't afford buying this drug.
That's an idea.
What is your experience in your daily practice with clopidogrel and the newer antiplatelet therapy?
That's an idea for a prospective randomized trial that we can conduct in not only in Tunisia, but we can do it in North Africa and even in a few African countries. And this is quite interesting because actually, as you said, because of the cost, you might run into the trouble of having a problem of adherence to treatment. So patients who cannot buy the more potent antiplatelet agents, they will just stop them. And if they stop them, then they will end up by having a stent thrombosis, which can be fatal in a high number of patients.
Even in European registries, American registries, the major antiplatelet prescribed is clopidogrel, isn't ticagrelor or prasugrel, because I think that they have also the problem of cost.
Okay, so any more question?
Maybe no.
Okay, so if there is no question, it's quite late now. It's almost 8 p.m. We have been working non-stop from 10:30 in the morning today. Thank you very much, Leila, and thank you, Fahmi, Professor Bousadia, thank you, Qais, and all the attendees who have been in a big number today, to a point that the system was blocked and many of our colleagues were not able to access. I hope that this technical problem will be solved tonight, because Millesima has promised that they will upgrade the system tonight in order to avoid any technical problems for the two next coming days. Thank you very much. Have a good evening, and see you tomorrow. We will start at 9 a.m. with live transmission from La Rabta Hospital in Tunis with the VSD closure. Thank you very much. Bye-bye.
Thank you. Bye.